HIV is a major problem in Africa, so it needs to be considered when children present with a variety of symptoms. Here we will look at the virus from a health worker's perspective. What is it? How do we recognise the symptoms? And what do we do about it? A child born to an HIV-infected mother may also have HIV infection. A child may acquire HIV through two ways: from transmission from the mother or through parenteral inoculation with infected material during blood transfusion, or through the use of contaminated needles. Maternal transmission of HIV is the commonest mode of HIV infection in children. A mother can transmit HIV through three different stages: in utero 5 to 10%, during delivery 20 to 50%, and through breast milk 15 to 40%. A child with HIV may present with the following: recurrent fever, failure to thrive, or generalized lymph node enlargement. Ask for the mother's HIV status to establish a child's HIV exposure. Is it reactive, non-reactive, or unknown? Ask if the child has had any TB contact. For a child who is less than or equal to 18 months, and if the mother's HIV status is unknown, conduct an antibody test or rapid test on the mother or child to determine HIV exposure. If the mother's or child's antibody test is positive, the child is HIV exposed. Take a dry blood spot for DNA PCR testing. For a child greater than or equal to 18 months, the child is exposed if the mother's antibody test is positive. In this case, conduct an antibody test on the child. You must note or ask, does the child have one or more of the following: pneumonia, persistent diarrhea, ear discharge, acute or chronic, or very low weight for age? You then look or feel for oral candidiasis or thrush, severe sepsis, parotid enlargement, generalized persistent lymphadenopathy, and other AIDS-defining conditions. Confirmatory tests should be done at the earliest opportunity. This classification is to classify for HIV. The child must be assessed for all other conditions and treated appropriately. If the child has any danger sign, give pre-referral drugs and refer urgently. You do not have to classify for HIV, as this can be done later when the child has stabilised. The health worker checks the immunisation status for all sick children. Have they received all the immunisations recommended for their age? Do they need any immunisations today? The health worker uses his country's recommended immunisation schedule when he checks the child's immunisation status. He gives the recommended vaccine when the child is the appropriate age for each dose. In the past, some health workers thought minor illness was a contraindication to immunisation, that is, a reason not to immunise the child. They sent sick children away and told the mothers to bring them back when the child was well. This is a bad practice because it delays immunisation. The mother may have travelled a long distance to bring her sick child to the clinic and cannot easily bring the child back for immunisation at another time. The child is left at risk of getting measles, polio, diphtheria, pertussis, tetanus, or tuberculosis. It is very important to immunise sick and malnourished children against these diseases. There are only 3 situations at present that are contraindications to immunisation. Do not give BCG to a child known to have AIDS. Do not give DTP2 or DTP3 to a child who has had convulsions or shock within 3 days of the most recent dose. Do not give DTP to a child with recurrent convulsions or another active neurological disease of the central nervous system. In all other situations, there is a good rule to follow. There are no contraindications to immunisation of a sick child if the child is well enough to go home. If a child is going to be referred, do not immunise the child before referral. The hospital staff at the referral site should make the decision about immunising the child when the child is admitted. This will avoid delaying referral. Children with diarrhoea who are due for OPV should receive a dose of OPV, that is oral polio vaccine, during this visit. However, do not count the dose. The child should return in 4 weeks for an extra dose of OPV. Advise the mother to be sure the other children in the family are immunised. Give the mother tetanus toxoid if required. The last box on the assess side of the chart reminds the health worker to assess any other problems that the child may have. Since the assess and classify chart does not address all of the sick children's problems, the health worker will assess other problems the mother told him about. For example, she may have said the child has a skin infection, itching or swollen neck glands. Or the health worker may have observed another problem during the assessment. He identifies and treats any problem according to his training, experience and clinical policy. He refers the child for any other problem he cannot manage in the clinic. After finishing the module, assess and classify the sick child, aged 2 months up to 5 years, the health worker should move to the other modules as follows. 1. Identify treatment. 2. Treat the child. 3. Counsel the mother. 4. Management of the sick young infant up to 2 months. And 5. Follow-up.